Okay, hello, my name is Deborah Cohen, and I am the physician volunteer moderator for the MAVEN project. Thank you all for joining us today and our friends at Cherokee Health Systems for hosting today's session. Abnormal tests in pediatric endocrine practice with Dr. Paul Kaplowitz. Dr. Kaplowitz was on the faculty of the VCU School of Medicine in Richmond, Virginia, from 1982 to 2003, and then moved to Washington, D.C. to become chief of endocrinology at Children's National Hospital. He is a professor emeritus of pediatrics at George Washington University School of Medicine. His areas of expertise include short stature and thyroid disorders, and he is especially well known for his work on precocious puberty, a topic on which he has written many articles, chapters, and a book for parents. He has also been a strong advocate for reducing low-value care in pediatrics and pediatric endocrinology, and in 2016, with the AAP, he endowed the Kaplowitz Lecture on Cost-Effective Care in Pediatric Endocrinology, which is presented at the annual Pediatric Endocrine Society meeting. Since retiring from Children's Hospital in 2018, he's been volunteering at Neighborhood Health Virginia, a federally qualified health center in Alexandria. And with that, Dr. Kaplowitz, please begin.
Thank you, Deborah. So I want to first disclose that I have nothing to report in terms of commercial interests, competing interests, and that, as Dr. Cohen said, this project is accredited by ACCME for 1 hour of credit. So my objectives today are threefold. One is I'd like to discuss several cases involving somewhat or very abnormal endocrine studies to illustrate how an endocrinologist would interpret and act on the results, and also to discuss the more general issue of trying to define when a test is truly abnormal and how it relates or doesn't relate to the problem which led to the ordering of the test in the first place. And my real ultimate goal is to encourage doing less endocrine testing in situations where a truly helpful abnormal test is likely. So the first case, I'm going to present a series of cases, and what I would like is if you have a comment on the question about the case, you can put it in the chat, or you can hold your comments for the end. But this is a 13-year-old girl who's brought in for severe fatigue for the last 3 months. She has trouble getting up in the morning, and even after sleeping for 8 to 10 hours, her appetite is okay. Medical history is unremarkable. Everything, vital signs, physical exam is normal. And so you order a bunch of tests, and you find that her free T4 is normal, but the TSH is slightly elevated. So the question is, what would you do next? And these are options, and sometimes more than one option is acceptable. Repeat the thyroid tests right away. Consult with a pediatric endocrinologist, start thyroid hormone, and then try to get her seen by an endocrinologist as soon as possible. Or you could tell the parents that none of the tests ordered really suggest a particular reason for their daughter's fatigue. Are there any comments or right now as to which people would prefer, or should I move on?
We have we have one person that says option 1 and one person that says option 4.
Okay, well, that's good.
Another one for repeat the thyroid test.
Right. Okay. So I'm going to talk about another test, another frequent scenario before I discuss, both of them together. This time you've got a 10-year-old boy who's obese, and he's, it's very common practice to say, oh, obesity could be hypothyroidism. So this time the TSH is normal, but the free T4 is just a little low. So you could either refer to pediatric endocrine because you suspect primary hypothyroidism with a delayed rise in TSH. Because low free T4 and normal TSH can be seen with pituitary hypothyroidism, you could refer to rule out a pituitary problem, or you could view the results as, well, it's not quite normal, but it's benign, or repeat the tests, and if the results are the same, then refer. So I thought I would, at this point, review a little bit of thyroid physiology that's probably familiar to most of you. But when everything is working properly, an illness of the thyroid resulting in a low T4 and T3, as shown here, will result in a loss of negative feedback because the T4 and T3 both feedback on both the pituitary and the hypothalamus. So loss of this negative feedback will result in an increase in TSH with the goal of restoring normal levels. Did we get any more comments on what to do with that scenario?
For the first scenario, it was a lot of people who wanted to repeat the test, and others who wanted to tell the parents also that there wasn't a good reason for the fatigue. And in the last one, most answers are B and C.
B is rule out a pituitary problem, or yeah, I mean, those are quite different answers. So let's talk about, things that you should think about with these scenarios. First of all, you have to ask yourself if the out of range results are meaningful in the context of what they're complaining about, which in this case is severe fatigue. So patients with true primary hypothyroidism, even mild cases, will typically have a TSH of greater than 10 and a low normal or a low free T4. And, my general feeling is that if the TSH is greater than 20, they should get seen by an endocrinologist, fairly soon. But the symptoms are very variable, and they don't relate so much to the TSH, but to how long it's been going on and how long the free T4, which is the biologically active thyroid hormone, is. So secondary hypothyroidism will result in a low free T4 and a normal TSH, but this is really rare without other pituitary problems, such as severe, growth failure or diabetes insipidus, or, and then if you have a history of a brain tumor or radiation, that would certainly increase concern. So my advice would be to ignore the borderline low free T4 with a normal TSH. But if the free T4 is less than 0.7, that's when it's really, I think, important to repeat it. And you might want to repeat it using a more accurate method than the standard free T4 assay. And you can get your lab to order it by equilibrium dialysis. So basically what I'm saying is that the borderline abnormal thyroid tests don't need to be, seen right away. By the way, if you have those kind of tests, there's no reason you can't, send the results to one of our pediatric endocrinology volunteers, but these patients generally don't need to be seen in person. Okay. So now you're seeing a 15-year-old girl who complains of losing 10 pounds in the past 2 months without trying, despite the fact that she's eating just fine. And she also feels warm when other people in the same room do not. Her past medical history is unremarkable. So what would you look for on her physical exam? And rather than wait for the pause, I'll just tell you, these are the things that you're going to be looking for. A large symmetric goiter, tachycardia, usually 110 or above, and in this patient, and a blood pressure of 140/70, which is a wide pulse pressure, brisk pulses, and increased precordial impulse when you put your hand over the heart, warm, moist skin, and frequently the patient has trouble sitting still. So the question is, what tests would you order? Let's just say that you're limited to 2 tests. Which are the tests that you would order for this patient?
We have free T3, thyroid stimulating antibodies, free T4.
Okay.
TSH and free T4.
All right, that's a good one. So the point is that I want to make is that all you really need to confirm your suspected diagnosis is a total or free T4 and a TSH. And in true cases, these will not be borderline. The free T4 normal range of normal goes up to 1.6. In most cases, we'll have a free T4 at least twice the normal range. And always suppressed TSH, usually undetectable, less than 0.05. Other testing, which includes, T3, which is marginally helpful, various thyroid antibodies, imaging such as a thyroid scan, I would recommend leaving those to the discretion of the endocrinologist. What you really want to do is establish a diagnosis so that you can then hand off this patient and they will know, I am seeing a patient who has proven hypothyroidism, and they can get whatever tests they want. Okay, so the other point I want to make is, when do you really need to order thyroid testing? And first of all, keep it simple for screening. A total or free T4 and a TSH is sufficient in nearly every case. So when do you want to do those tests? Well, if you got a kid with a goiter, even if they have no symptoms of hypo or hyperthyroidism, particularly if it's recent onset, you need tests. If you're following up an abnormal newborn screening result, absolutely. If you have a child who's been growing normally, and then in the last year, the growth has, not just slightly declined, but really significantly fall off, you need to rule out hypothyroidism. And then, as in the case that I just mentioned, signs and symptoms consistent with hyperthyroidism. And, the symptoms of hypothyroidism are not as clear-cut and more subtle, but new onset fatigue, not, my kid is always tired, but this has happened in the last few months. And, the patient says, I'm really cold all the time. So those are really the major reasons. But thyroid tests are really low yield for obesity, for most changes in behavior, a family history of thyroid disease, and irregular periods. You're rarely, if ever, going to find abnormal tests. And the reason why, people say, well, obesity, that's an important cause. Yes, for hypothyroidism, but hypothyroidism and other endocrine disorders, such as Cushing's disease, are really rare causes of obesity. And the weight gain in severe hypothyroidism is really modest, and it's in the range of 5 to 15 pounds, not the 40 pounds that you're seeing. And it's really due to fluid retention, not excess fat. And a lot of times these patients will actually have a puffy round face if it's severe and long-standing. There was one report from Germany back in 2007 which said only 0.3% of children evaluated for obesity had hypothyroidism, and I imagine some of them were only mild hypothyroidism. So the important point is that we often see patients, whoops. We often see patients who present with non-specific complaints, such as fatigue or very common problems such as obesity, that don't really point to a specific medical explanation. And in hopes of finding an explanation, sometimes you may order a large number of tests to make sure that we're not missing anything. And metabolic panels and CBCs are sometimes ordered for screening purposes without any complaint at all. And when one of these tests is mildly abnormal, should we assume that the abnormal test is clinically significant? The problem is that the boundary between normal and abnormal is much fuzzier than many people are aware. And the definition of normal in most labs is the 95% confidence interval. What does this actually mean? What that means is that, here's the normal range. And the 95% confidence interval includes this whole area, but it also excludes this area, which is part of the normal distribution. Whereas the 99.7 range is a much smaller, much less likely to be part of the normal distribution. So does this make any result which falls outside of the 95th percentile truly abnormal? And how do we know that if a person whose test result is just outside these limits has a normal variant or real disease? And it's further complicated by the fact that for some tests, a normal range varies with age, but the normal range given by the commercial lab may not reflect this. A good example is T4 levels. If you get a T4 in a 3-day-old, it's going to be a lot higher than in a 1 to 5-year-old, and also higher than in a 6 to 10-year-old or an adult. And this is especially true of puberty-related labs. I recall that one commercial lab gave the normal testosterone range for boys as 240 to 800, and that's really the adult normal range. And then a pediatrician who saw that their child had a level of 150 in a 15-year-old boy, which is quite appropriate for mid-puberty, thought that that was too low and needed to be evaluated. And the other problem is that with interpretation is that some tests have a very tight normal range. So even a small deviation may be clinically relevant. For example, a normal serum sodium of 135 to 145 is a pretty tight range. So a sodium of 149 could be meaningfully abnormal, especially if you're evaluating a child with polyuria and diabetes insipidus is a consideration. Recently, I was consulted by a provider on a 2-year-old with new onset seizures, and she was concerned because the calcium was low. Well, yeah, it was low, but only slightly low. And the truth is that borderline low tests like this do not result in dramatic symptoms such as seizures. For seizures, most of the time the calcium is going to be less than 7 or less. All right, let's move on to another case. A 5-year-old overweight Hispanic boy is sent for some screening labs. 3 days later, you receive a report that his CVC and urinalysis are fine, but on the metabolic panel done at 10 a.m., his glucose is 118. The parents tell you that he always drinks a lot. So what would you do? Order hemoglobin A1C, refer to a pediatric endocrinologist for a type 2 diabetes evaluation, repeat the glucose, but make sure the child is fasting, or order a 2-hour OGTT with insulin levels. So let me give the group a minute to type in some answers.
I think most people would pick C, repeat the glucose, but make sure it's fasting. And other people would also like to order an A1C in addition.
Okay, well, that's good. So here are some things to consider. While type 2 diabetes is becoming more common in obese children who are over 10 years old, it rarely presents as young as age 5. So I discourage ordering A1Cs in kids that young. Now, a random blood sugar of 118, if the child had consumed a lot of carbs 1 or 2 hours earlier, such as this child didn't come in fasting, but probably had eaten breakfast. So a random blood sugar of 118 is likely normal. And since the renal threshold for glucose is around 180, polyuria and polydipsia would not be expected for a mildly elevated blood glucose. And remember, these parents did not report new onset polydipsia. It's been going on for a while. So the conclusion that I would draw is that this is unlikely to represent diabetes, either type 1 or type 2. But fasting blood glucose would be the best follow-up test just to reassure the family. The other problem with A1Cs is that it's too often in that murky at risk for diabetes category of 5.7 to 6.4 in children who really don't have either diabetes or prediabetes, particularly when it's 5.7 to 5.9. So, A1C is sometimes a value, but not in this particular scenario. And here's another scenario. A 5-year-old boy had a screening urinalysis, and he had 2+ glucose. And so you get that and said, we should get a random glucose on a, they were in a hurry, so they didn't wait for the kid to be fasting. They sent him to the lab, and on the on the BMP, everything was normal except the glucose was 225. So the parents deny any history of polyuria and polydipsia. So how would you proceed? The first one is have parents remove high sugar drinks from his diet. I didn't say whether this kid was obese or not. Discuss this case with a pediatric endocrinologist, maybe even by phone call as opposed to email or faxing. Do an OGTT with a hemoglobin A1C, or have the blood sugar repeated if and when symptoms suggestive of diabetes develop. So I'll wait a minute for.
We have mostly A answers and a couple with B.
Okay.
Mainly B and a couple with A.
Okay, that's what I would have thought. All right. So things to consider is that a random blood glucose of greater than 200 is diagnostic of diabetes, even in the absence of symptoms. If the random blood sugar is 150 to 200, that's pretty suggestive. So that would be unless the child is on medications such as high-dose steroids, which can, temporarily elevate the blood glucose levels. And, considering that this is at age 5, this is most likely early type 1 diabetes. So during the time it might take to schedule and review results of an OGTT, your patient might progress rapidly and become quite sick. So having a pediatric endocrinologist involved early will make sure that any definitive testing, which might include a fasting glucose or an OGTT or a hemoglobin A1C, is done promptly and acted on quickly. Because one of the things you don't want to do is order these tests on a Friday, have the results, not have the test not be resulted until early the following week, and then the kid becomes sick over the weekend and ends up in the hospital. All right.
There is a question, one question, Paul, why did he originally get labs?
Because the pediatrician decided that kids should have yearly screening labs. There are, many people who in their practice feel like they should order, CMPs and, CBCs to, screen for disease even in the absence of symptoms. So this would be one of those rare cases where it actually picked up something of value. But I don't recommend, this as a general practice, and had the patient not had, this test result, probably within a couple of weeks, the parents hopefully would have noticed that he was drinking more, going to the bathroom more, and have, contacted their primary care provider. But good question. Okay. So now we're going to talk about a sort of a clinical scenario, not so much a lab scenario, that I think many of you will be familiar with. And that is the 7-year-old girl who's found on her child check to have pubic hair, Tanner stage 2, and underarm odor for the last 6 months. Her height is 90th percentile, weight is 95th, and there is no breast development. Genital exam is normal except for the pubic hair, and the parents do not seem extremely worried. What would you do next? So your options are order LH, FSH, and estradiol to rule out precocious puberty, order a different panel of tests, reassure the parents without testing, or send to pediatric endocrinologists and let them decide what to order. So I'll wait for your answers.
We have a question as to what race, ethnicity she is.
Oh, okay. Well, that's an interesting point. Let's say she's African American.
So far, we have all 3s and 4s, and
Oh.
one unsure.
All right. Excellent, excellent. So I think whether you pick the 3 or 4 are the options that I would have endorsed. And it really, whether you choose 3 or 4 really depends on your familiarity and comfort with this, entity. But let's just say you decided on option 2 and you did these tests and got these test results, then you would have to decide what to do with them. And so, the next move might be tell the parents about what you expected, but you still want them to see a specialist since we know that DHEAS comes from adrenals, order a CT scan of the adrenals, or ask your local pediatric endocrinologist to see your patient to rule out a virilizing tumor. Well, fortunately, the people who responded did not choose option 2, so you didn't have to decide which one of these options, but you clearly don't want to, worry about an adrenal tumor. So this is a classic case of what we call premature adrenarche. Some call it premature pubarche. And it's really a benign normal variation of puberty. And we define it as if it shows up before age 8 in a girl or age 9 in a boy. So typically, and to address that earlier point, it is considerably more common in African American girls and boys than in Caucasians. And studies show that in 7 to 8-year-olds, 3 times as many African American versus Caucasians have pubic hair. So typically, the only abnormal finding is an increase in DHEA sulfate, the major circulating adrenal androgen. But knowing that the DHEA sulfate is high doesn't really, other than to say, yep, it's from the adrenal glands, it doesn't really help in your management. You definitely don't want to order LH-FSH and estradiol because those are really only helpful if breast tissue is present. And sometimes commercial labs will give inaccurate results for testosterone. They'll tell you the testosterone should be less than 10 and it comes back 20. But if the testosterone is less than 30, it's not a big worry. But virilizing tumors or congenital adrenal hyperplasia, which can sometimes present late, causing early pubic hair is uncommon. And typically with, a virilizing tumor, you're not just going to see pubic hair, but other signs of virilization, such as an enlarged clitoris. So the group did very well on that case. But, so if you're comfortable with saying, yep, I've seen this a lot, I'll monitor it. If it doesn't, progress, I won't refer. Or you can refer for 2 reasons. One is if it seems to be, it will progress slowly over time. But if the kid's growing rapidly, the pubic hair is progressing rapidly, please refer. Or if the parents are worried, sometimes the parents haven't even noticed it and aren't worried at all. But if the parents are worried, yes, you should refer. Okay, so let's now talk about an overweight 10-year-old child. Let's make him a boy. And you decide to screen him for vitamin D deficiency because you have heard that, obese kids are more likely to have low vitamin D levels. So the 25-hydroxyvitamin D, which is the correct test to order to screen for vitamin D deficiency, comes back as 20.5, and the lab gives you the normal range of 30 to 50. You've also ordered a CMP, and his calcium and his alkaline phosphatase are normal. So my question is, would you prescribe high dose of vitamin D weekly for 8 weeks? would you assess his vitamin D intake, which is usually in the form of milk or multivitamins, and you also might consider, how much sun exposure he gets. And if, you think his intakes might be low, you could suggest a daily vitamin D supplement, at least 1,000 units a day. Or you could say, that vitamin D level is fine and do nothing. So let's wait for some responses. And by the way, you can respond to I'm sorry I didn't number these, but you can give 2 responses.
The main responses are to assess intake, assess and also supplement. One response, I would not have ordered the vitamin D lab. Having seen the labs, I would suggest he play outside. And another response is a daily dose of 1,000 units.
Okay, well, good. Interestingly enough, it's not uncommon for providers to say, low vitamin D, gotta get that up quickly. And you can certainly get it up quickly with 50,000 units a week for 8 weeks, but then you have to, then if you stop it, eventually the vitamin D level will come back to normal. So this is what you need to know about vitamin D. While the Endocrine Society recommends that 25 vitamin D levels should be in excess of 30 nanograms per L, most experts actually feel that any level greater than 20 is adequate, and that evidence of D deficiency is really rare unless levels are less than 12. So, when should you measure vitamin D? It should mainly be done when you, unexpectedly find hypocalcemia, especially in the group that's most at risk for vitamin D deficiency in our practices are breastfed, dark-skinned infants who are not taking vitamin supplements, or you find evidence of rickets either on a physical exam or an X-ray. And for others, including kids with obesity who, yes, do tend to have lower vitamin D levels, it's really best to assess milk intake and sun exposure and advise a daily supplement if vitamin D levels, you think they might be low. And in this case, well, the vitamin D level was, borderline, but not super low. So you could either do nothing if your assessment is they're drinking milk, they're out in the sun, or it's, inexpensive to, prescribe a low dose supplement. But this approach is far more effective than getting a vitamin D level, let's say the level was 18 instead of 20, and then you're going to do something, and then you're going to get another vitamin D level, and then you might get another one. And it becomes really expensive. Vitamin D assays are not cheap, over $200 a test. So what you're doing is by, monitoring vitamin D so often, you're really adding costs, but you're really not benefiting the child. So those are the cases that I have, but I wanted to kind of, get some more general points about test ordering. So ordering more tests than is necessary really has a significant contributor to the rapid rise in healthcare costs for children without really making children healthier. And this is particularly true of tests ordered for completeness when the H&P do not point to any specific diagnosis. And, so I know that most of you probably don't order, tests, CMPs and CBCs on, for patients that don't have any complaints, but there are people that do this routinely in their practice, figuring, they're going to offer a higher level of service and not miss anything. But what often happens is one abnormal result often leads to retesting, and then get a spiral of more testing and more abnormal results. And one example of the unnecessary testing is the mildly short child who was growing normally close to the 5th percentile. So what workup is needed for a healthy short child? There was a study published in 2013 from Cincinnati, which looked at the diagnostic value of the typically ordered screening tests in over 300, it's actually over 300 short children with a normal H&P and a normal rate of growth. And they really only found one patient, and this is a child who was very short, who was found to have a lab test that was clearly related to his short stature. And that was a very high tissue transglutaminase IgA antibody leading to a diagnosis of celiac disease. And this was the reference to that article. And, you might wonder, how much would that work up? These are the tests that they really looked at. And not everybody ordered all these tests, but, if you look in a textbook for short stature, what should I order? It won't tell you you have to order all of these tests, but it may suggest that you might order all these tests. So then you go ahead and order all these tests. And you find that now this is children's, and children's charges more than commercial labs, but at children's, and the insurance won't always pay the whole cost, but at children's, the total of these screening tests, the charges are going to be over $2,000. By the way, I want to point out that if you're doing screening and you don't have a high suspicion of something abnormal, you can save over $100 by ordering a total T4 versus a free T4. So some final thoughts is one reason that there are so many abnormal test results is that often so many tests are ordered for patients with weight issues, mild short stature, fatigue, that, you have to remember that 5% of healthy kids will have values outside any lab test normal range. So if one orders 20 or more tests, there's a good chance that at least one result will be abnormal. So I would suggest that, in most situations where, you're not worried about, something, serious and life-threatening, that you hold off on non-selective test ordering while monitoring the patient for the problem that they bring to you. Now, the most common type of question I get as a MAVEN volunteer is, I saw this patient with X and ordered, and they give a long list of tests. What other tests should I order? And you may want to ask what tests might be, ask us what tests might be helpful for a specific scenario before you start ordering. We are happy to, to give opinions on this. If it's a short kid, you can certainly attach the growth chart. But when confronted with an abnormal test, please consider whether the result is likely to be abnormal in a clinically significant way before referring the child to see a specialist in person. Test results which are slightly outside the reference range rarely, if ever, cause symptoms. And, the other question is, how important is it to distinguish subclinical disease states from what we would consider normal variations? But there are times when you have a test result well outside the normal range, and that's a different story. So, one more thing before I finish. Parents of a okay. Yeah, I think I am pretty much done. So we have 15 minutes for questions. I'd be happy to entertain questions about the case scenarios that I presented, but also, I'm sure that you have encountered situations where you weren't sure what to do with a endocrine result, and I'd be happy to give my opinion.
While we're waiting for people to put some questions in the chat or Q&A, I'm wondering about the role of thyroid antibodies in evaluating patients with TSH levels that are 7, 8, 9, 10. What do you think about that?
It's a good question. First of all, what I would recommend doing, and you can do this without consulting an endocrinologist, is if you have a patient with a normal free T4 and a TSH of, in that 5 to 10 range, my suggestion is to repeat it, but wait a minimum of 6 months. The reason for waiting 6 months is that it gives time, because these borderline TSHs, half the time they revert to normal, half the time they remain borderline, and only 5% of the time do they actually go up high enough to really merit treatment. So my suggestion is wait at least 6 months. You can wait a year too, and then repeat the test, because even if they go up, they're not likely to go from 6 to 60. But when you repeat them, I think it's, as Dr. Cohen says, I think it's fine to add a thyroid. The thyroid antibody that I would add is the thyroid peroxidase antibody, because if you have, still a borderline TSH, but not a borderline, but a very high TPO, that patient may have early autoimmune thyroiditis, and that patient is going to have to be tested more often than if the antibodies are negative. So very good question.
Great. Thank you. And our first question is, any thoughts on lipid screenings?
Yeah, you're a little outside my area of comfort, because, some endocrinologists do, get involved in treating kids with, mildly with abnormal lipids. The guidelines suggest that, lipids be screened. I don't know if it's at age 10 or at age 12, at least once. And, what we don't want to do is unleash an epidemic of using statins on kids with borderline, elevated, LDL cholesterols. But one of the reasons for screening for lipids is that there is a condition called familial hyperlipidemia or hypercholesterolemia that is inherited as an autosomal dominant. And you'll frequently get a history of a parent who had a heart attack, cardiac event before age 50. So, and it's not a rare condition. So it's, might not be a bad idea to screen, kids once when they're around age 12. But as far as, decision as to who to treat, where I live, we usually would, if it really seems that the LDL cholesterol is way above, not just a little, but, way above the reference range, to refer those patients to pediatric cardiology.
Okay, thank you. Short stature only on well child checks, and parents are short. Any labs or evaluation?
Yeah. Well, I think, first of all, it helps to review the growth chart. It's tricky if you are seeing the patient for the first time. But if you have a growth chart, let's say the child is below the third, below the third percentile, but the points are tracking parallel to the third percentile, and the parents are short. And by short, I mean mother's 5'5", 5 foot, foot or less, and father is 5'6" or 5'5" or less. Then there's a strong likelihood that you're dealing with familial short stature, and the yield of significantly abnormal results is going to be very, very low, as I indicated from that paper that I cited. And so ordinarily, if the kid seems healthy, the weight is appropriate for the height, or they're a little overweight, but they're not skinny, I would not order any tests. Now, the problem you run into is that I don't know in your clinics whether you have pushy parents, but some parents are going to say, my child, is too short. He's shorter than his peers. His self-esteem is poor. I want to get him tested for growth hormone deficiency. Well, then you have a couple choices. If the parents are really pushing it, you could get a IGF-1, which is the screening test for growth hormone deficiency. You just have to make sure you interpret it by the, normals for age, because that's another test that's age dependent. Or, if the kid is, first of all, if the kid's at the 10th percentile, I would not refer the kid to an endocrinologist. If the kid's third percentile, I probably wouldn't. But if the kid's significantly below the third percentile and the parents are, very concerned that this kid is, something might be wrong, then I think it's reasonable to have them get a non-urgent appointment with your local pediatric endocrinologist.
Right. Thank you. I agree. Another question is, say the thyroid antibodies were already checked in that scenario and are positive, TSH is under 10. How often do you recheck? And you did mention 6 months, but after that, how often would you recheck?
Well, it depends. If the levels are very stable, like let's say it's a 6 and then it goes to a 5 or a 7, I might spread it out to a year, check in a year. If the level goes from, 6 to 9, I might check it in 6 months, figuring that that might be a trend. But so in general, I would say 6 to 12 months. But I want you to keep in mind that it's very rare for these cases of subclinical hypothyroidism to, become severe hypothyroidism in a 6 to 12 month period. So, either 6 or 12 months is fine.
Okay, thank you. And another point of information from Rebecca Rowland. For your information, for you Knoxville providers, per Dr. Hurst, pediatric cardiology doesn't manage hyperlipidemia. They should go to GI or endocrinology. And I would just comment that in my own area, there actually are either pediatric lipid clinics or adult lipid clinics that will often handle these patients, but pediatric endocrinology does become the triage system for those patients. So I think, thank you. I do agree that there are going to be different referral patterns for lipid problems in different areas.
It's a very good point.
And another question, here's another. Yeah, we have a peds lipid clinic at Vanderbilt, but that's a ways out. Sure, our Knoxville endocrinology team is agreeable to see them. Okay, and I think Dr. Kaplowitz had said about screening at 10, and then I think maybe the next screening is as teenagers. So hopefully you're not getting lipids too often. Any other questions in the chat or the Q&A?
Yeah, could you give them my email address? It's
Okay.
PKAPLOWI at childrensnational.allruntogether.org. So, I am retired and I have time to check my email more often than I should. But if you think of a question that you didn't get to answer or have a question that you didn't really want shared in public, please feel free to email me, say, I attended your talk and it was very helpful, but I have this other question. So I am happy to help.
Okay, well, I think that's all the questions. Thank you so much. I think this was really informative and helpful on a number of levels, and we'll give everybody an extra few minutes for their day. And thank you from an internist, according to the chat, and we do appreciate your time, Dr. Kaplowitz. Thanks very much.
All right. Thank you, Debbie.
You're welcome. I'm going to stop recording.